who are these kids, who are the vulnerable kids, and where are they actually dying? And then distill all of that information for programs like myself and my sepsis program to try and understand where we should be targeting our efforts to improve sepsis outcomes. Next slide, please, Bex. So just as a little reminder, sepsis is a condition that always starts with an infection, but in some people that progresses on to impacting the organs. Those organs begin to function poorly and eventually fail. And the reason that we talk so much about sepsis and septic shock is because there's a vast change in mortality rate going from infection to sepsis. And if you look at all-cause mortality in our pediatric intensive care unit, so those are all the really sick kids with scrambled hearts, massive car accidents, all of those sort of things. Our all-cause mortality is 2.5%, which isn't very high compared to an adult intensive care unit, which would be running at about 8 or 9%. Whereas the mortality for sepsis in children in Australia today is running at 17 to 19%. So it's a 10 times increase in mortality from our baseline. And that is why this is important. Next slide, please, Beck. I think this is over to you, isn't it?
Yes, yeah, that's good. All right, thank you, Paula. Okay, so our cohort for this study was infants and children aged birth to 17 who were recorded in the Queensland Child Death Register who died from either explicit or implied sepsis in Queensland between 2004 and 2021. For most of the analyses, we then subsequently excluded infants who died without having ever left hospital after birth, or those born unexpectedly at home in very poor condition who died shortly thereafter. And this is because we really wanted to be able to distinguish between paediatric and neonatal sepsis. So there's widespread recognition that neonatal sepsis, which is sepsis in usually very preterm, very low birth weight infants in a neonatal care environment, represents quite a different clinical problem to what can generally be thought of as paediatric sepsis. Cases where children died in a dedicated palliative care facility were also excluded. Again, here we were interested in preventability, and these children would likely have had a ceiling of care that would prevent the active treatment of sepsis. So to ensure that we captured all deaths due to sepsis, we linked data from the Queensland Child Death Register with perinatal, hospital admission and emergency presentation data, as well as coronial information. We used a modified version of the Global Burden of Disease Study mortality and morbidity codes for explicit and implied sepsis. And this is the accepted method for identifying sepsis deaths and hospitalisations internationally. Identifying explicit sepsis is pretty straightforward. Cases are identified as explicit sepsis if they have an ICD-10 code referencing sepsis explicitly in the chain of causes of death or in the hospital diagnosis codes from the final hospital admission in which death occurred. To understand implied sepsis, however, it's important to recall that the clinical definition of sepsis is infection plus new organ dysfunction. So taking this definition, sepsis is implied in cases with an ICD code for infection in the chain of causes of death or hospital admissions, and there are ICD codes or keywords for organ dysfunction present also in the cause of death or the final hospital diagnosis codes. So just as in the clinical definition, the presence of both an infection and an organ dysfunction code implies sepsis. We also looked for the presence of sepsis in coronial findings for reportable child deaths. So this flowchart highlights the value of data linkage in identifying sepsis-related child deaths. So as I just mentioned, we started with all infection-related child deaths in Queensland, and we linked these records with perinatal hospital admission and emergency data collections. We then looked for explicit and implied sepsis in the coded and uncoded cause of death information. So based on the death certificate or death registration data alone, we were able to identify 320 sepsis-related child deaths. But adding hospital admission and emergency presentation data identified a further 102 cases. Hospital records were also used to upcode cases identified as implied sepsis to explicit sepsis. And finally, we hand searched autopsy reports for mention of sepsis in the findings. And through doing this, we were able to identify an additional 22 cases. So in total, in terms of paediatric sepsis, we identified 444 cases. So this really shows the value of data linkage in these population-based studies of sepsis. It also points to the underdocumentation of sepsis on cause of death certificates. So despite our best efforts, though, we think that there are additional sepsis-related child deaths that we have been unable to identify. And this is because once we had screened all the infection-related child deaths to identify sepsis cases, we noted a large residual pool of deaths that involved infection but without evidence of sepsis. And most of these residual non-sepsis infection-related child deaths occurred in the community. So these findings give rise to a suspicion that a proportion of infection-related deaths in the community may involve sepsis. Difficulties associated with diagnosing sepsis in live patients in hospital settings have been extensively reported, and these are compounded post-mortem, particularly where the death occurs in community settings where antecedent clinical data may be scant. So I'll just, before I hand back to Paula to talk through some of our findings, I just want to quickly go through a couple of our explanatory variables that weren't straightforward in definition. So to identify children with medical complexity in the study, we applied a modified version of the Paediatric medical complexity algorithm, and this is a validated tool for identifying medical complexity in paediatric patients. So using this algorithm, children were classified as having a chronic complex disease if they had either a significant chronic a significant chronic condition in 2 or more body systems. They had a progressive condition with deteriorating health and decreased life expectancy, or they had a progressive or metastatic malignancy. We also classified children as dying in either hospital or community settings. So here we looked at the place of death as recorded on the death certificate for non-reportable deaths, but we also used the coronial information, including the police summary of circumstances for child deaths that were reported to a coroner. And importantly, we classified children who arrived at hospital moribund, usually under resuscitation, as dying in the community, as this is the environment where the initial collapse or the profound deterioration occurred. And this approach is consistent with the classification of sudden unexpected deaths in infancy. So finally, throughout this report, we've equated deaths reported to a coroner with unexpected deaths. And this is because in the context of paediatric sepsis and other infection-related child deaths, deaths are usually reported to a coroner because they were sudden and unexpected, such that it was not possible to form a medical opinion about the cause of death. So occasionally sepsis-related deaths may be reported because the child was in care or because they're a healthcare-related death, but this is rare, and it indicates that reportable deaths actually function very effectively as a proxy indicating that the death was not anticipated by clinical history. Okay, I'll now hand over to Paula for the
The key finding here is that there we go, is that paediatric sepsis really is a significant cause of preventable death in Queensland. So over that 17-year period, there were some 8,000 deaths amongst Queensland's children, and the vast majority, 72% of those, were from natural causes. And having applied our methods, we found that there was sort of 750 odd deaths in children were due to sepsis. And we excluded, as Beck said, the neonatal sepsis to leave us with 444 paediatric sepsis cases. And if you were to take the neonatal and the pediatric sepsis cases together, that gives us a rate of 3.8 per 100,000 live-born children, which far exceeds any other natural cause of death in children in Queensland. And when we look specifically at pediatric sepsis of a rate of 2.3 per 100,000 children, that is similar to the next biggest cause of natural death, which is childhood cancer, but it's also similar to those non-natural or external causes of childhood death that actually also have really big public health campaigns for them, and we're all much more aware of, for example, like pediatric drownings and youth suicide. So there is a real opportunity, I think, here for us. Next slide, please, Beck. The other interesting thing is if you divide the 17 years into two, you can see that actually pediatric sepsis is reducing in incidence all by itself. This is prior to any intervention or program having happened. So it used to be about 2.6 per 100,000, and that's now decreased by to 2, and that's about a 23% decrease over time. Now, this data is actually at odds with the Australian Commission's data that they used for the sepsis care standard, which looked at both adult and pediatric data in the hospital setting. So it's hospital data only, not including community, where they showed that the incidence of sepsis actually was going up, but sepsis mortality was staying the same, whereas we've shown in children it seems to be decreasing. But it's not uniform, the decrease. What we have seen is that if you separate our Indigenous and non-Indigenous populations, all of the improvement is happening in our non-Indigenous populations, and our First Nations children mortality rate over 17 years has not changed. And the result of that is that the gap in health equity is now widening. So our First Nations children are dying at a rate of 3.6 times that of our non-Indigenous population. And it's important to note that 20% of pediatric death due to sepsis are in the Aboriginal and Torres Strait Islander population, whereas they form only 5% of our Queensland population. So that's a pretty stark and worrying feature of this data. Next slide, please, Beck. So when we just had a little look at a little bit more of a deep dive into our Aboriginal Torres Strait Islander children, it's not a surprise, because this I mean, we saw it in our talks earlier today. It's not a surprise that the deaths of our Aboriginal Torres Strait Islander children, they are 4.5 times more likely to come from a socioeconomic disadvantaged area. They are much more likely to be living rurally and remote, and in fact 15 times more likely to be living in the remote or very remote regions. But interestingly, they are also younger. The median age of these kids is 1.4 against 3.6. They tend to be previously well and not have these complex medical conditions. And a greater proportion of these children are actually dying at home or in the community as compared to the non-Indigenous counterparts. And they are also unexpected, which means they are not anticipated. They are more likely to be reported to the coroner. And those last 4 facts, to me, circled together, it represents an opportunity. These are children, these are deaths that we can prevent. They're young, they're happening at home, and they're in previously healthy children. So these are the children and the families that we should be targeting to improve our outcomes. Next slide, please, Beck. When we look at medical complexity, it's no great surprise that about 50% of our children who are dying of sepsis have complex medical conditions. To me, that's what I expected. I really didn't expect that nearly half, so 44%, would be previously well. I knew there would be a reasonable percentage, but not quite that high. And it's no surprise to me that those children with complex medical conditions are largely dying in hospital, nearly 90% of them. And of those children who are dying with chronic conditions, the vast majority of them are anticipated. So only a third are reported to the coroner. So the fact that they're dying in hospital, there's a little bit of my brain that's thinking, okay, so these parents are probably more health literate. They're probably very able to advocate for the child because they are used to navigating the hospital system. They probably have improved health-seeking behaviours, and they probably have easier access to healthcare because of the long-standing nature of their child's condition. The previously healthy children were nearly half of them, and only about half of those children made it into hospital to die. So we have a very significant number of previously healthy children dying in the community of sepsis and not making it into hospital for ongoing treatment. And not surprisingly, these are unexpected deaths, and the vast majority of them were reported to the coroner. Next slide, please, Beck. And we showed earlier on the algorithm, Beck showed you that, you know, the division between children dying in the community and children dying in hospital was about a third were dying in the community. And these children were more likely to be healthy. They were more likely to be young. So there were greater numbers of them under 3 years of age. They were more like the Aboriginal and Torres Strait Islander communities were overrepresented in that cohort, and they were more likely to be reportable. Next slide, please, Jake. So if we look at that 131 deaths in the community, about 85% of those deaths were reported to the coroner. So we actually were able to, there was more information about those children than we would ordinarily have had. So we were able to dig into them a little bit more. But clearly there were no linked hospital records because the children hadn't made it into hospital. But when we looked at these deaths a little bit more closely, 84% of them were known to be unwell in the preceding couple of days prior to their deaths. But 16% the parents thought that they were well. And in fact, if they were under a year, they were least likely to be symptomatic. And that is a bit of a problem. But of those 84% who were known to be unwell, at least half of the parents didn't think their child was unwell enough to go and seek a healthcare professional's opinion. So they missed entirely that their child was deteriorating to the point of death. So that 16% and that 52%, to me as a clinician, I see as an opportunity. We really do need to be educating parents around what the signs and symptoms of infection and deteriorating infection, and therefore sepsis, is, because those parents didn't think there was a problem. But about half of the parents actually did seek healthcare contact. And of those who sought healthcare contact, some of them did it, 10% did it on more than 4 occasions, on 4 or more contacts, and some, a quarter of them, or a third of them, were 2 or 3 contacts with healthcare professionals. So there's something that we need to unpack there too. I know from that there is something around clinicians being able to pick up sepsis, but we also know that children can be present to a healthcare professional, they can look okay and be discharged back into the care of the community and then deteriorate at home. But parents are reassured by having had an earlier consultation that won't happen. So there is a big piece here to be done around safety netting. Firstly, that parents understand it's not necessarily a mistake of the doctors that they didn't see the sepsis straight away, but that if the child deteriorates after a consultation, it is absolutely okay to go back and seek healthcare opinion. So to advocate for a representation. And on the other side of that, we need to be teaching our clinicians that when somebody comes back for a second, third, or fourth time, that there is significant parental concern here, that must be a red flag that this child is deteriorating. And we need to as clinicians, pay attention and respect that. The other key little bit of information is here is that of the contacts with healthcare professionals, the vast majority of them were within 24 hours of death. And when we dug into that number, again, Aboriginal and Torres Strait Islander children were formed about 80, were more likely to be in that short consultation period, so 82% versus 67% of their non-Indigenous counterparts. So to me as a clinician, there is also we need to make sure that our screening tools for sepsis are adequate for darker skinned children. And we know in the post-pandemic era, looking at data from the COVID pandemic, that some of our saturation monitoring screening tools underperformed and missed sepsis in children and adults who had darker skins. So there's quite a lot to unpack in the slide. And for us as clinicians moving forward, we know there's public health campaign, there's a campaign around safety netting, and there's a campaign around clinicians understanding representation is a red flag, and there's also something around looking at our screening tools with and evaluating them in darker skinned individuals. Thank you. If you could move on to the next slide, please. So these are our really headline findings. Paediatric sepsis is a significant cause of preventable mortality in Queensland. The rate of it, the incidence of it, is reducing overall, but not in our First Nations population. And in fact, the rate ratio is widening. Our First Nations children, our children in remote and socioeconomic disadvantaged areas, infants, toddlers, and preschool aged children are overrepresented in the figures. And while over half of our children who die from sepsis have chronic health conditions, and they do have a higher risk and severity for sepsis, we need to acknowledge that nearly half of our paediatric deaths occurred in previously healthy children, and a third of deaths happened in the community before children could access resuscitation help. Next slide, please, Beck. Over to you, I think.
Yes, all right, great. So the report and our study made a number of findings and recommendations that are designed to improve sepsis recognition and clinical care. So as we've just seen from that discussion of deaths in the community, primary care, and in particular general practitioners, are often an acutely unwell child's first point of contact with the healthcare system. Unfortunately, sepsis recognition in pre-hospital settings is known to be both challenging and poor. So children who have presented to healthcare services, such as GPs and hospital emergency departments prior to dying in the community or arriving at hospital moribund, are a very important group of sepsis and infection-related deaths. So it was really clear that this cohort could benefit from preventative strategies to improve the early recognition of sepsis by families, by primary health services and emergency departments to allow early treatment and improved outcomes. So we therefore recommended that sepsis red flags be embedded into the infection health pathways of all 7 primary health networks in Queensland. So health pathways are evidence-based guides designed principally for general practice teams that contain information on assessment and management of common clinical conditions, and they importantly include local referral options. As Paul has just discussed, it was also clear from the review of contacts children had with the healthcare system that children seen by a health professional with suspected infection should be sent home with appropriate safety netting, highlighting the signs of further deterioration. The repeat presentations for a substantial number of children also highlight that importance of including parents as members of the healthcare team and ensuring that parental concern is a recognised indicator of serious illness. The disparities between Aboriginal and Torres Strait Islander and non-Indigenous children also demonstrate the need for culturally safe and responsive sepsis care across Queensland. So we also recognise the need to improve parental and caregiver awareness of sepsis, which is known to be low in people of parenting age in Australia. And therefore we recommended the development of media campaigns designed to increase caregiver and community awareness of sepsis and its symptoms. Culturally safe campaigns aimed at Aboriginal and Torres Strait Islander communities are also needed. The large number of unexpected sepsis and other infection-related deaths occurring in the community, often among previously healthy children, highlighted the pressing need to improve our understanding of the antecedent factors and the child's clinical presentation leading up to death. Currently, coronial investigations rely on police who have limited clinical knowledge to collect clinical information from families and healthcare professionals. Unfortunately, what this means is that often really important information about the oftentimes subtle signs and symptoms indicating the progression of disease, that is, from infection to sepsis, as well as information about caregiver awareness of the same, is seldom collected as part of the routine investigation of these deaths. So we therefore recommended that coronial investigations of unexpected infection-related deaths involve a paediatric healthcare professional to gather and record a detailed clinical history, including underlying medical conditions, vaccination history, and touch points with health services in the lead up to death. General practitioner and other health service records, including any lab tests and culture results, should also be obtained during this coronial investigation and reviewed. The report also suggested that there may be benefit in developing forensic autopsy guidelines to improve sepsis recognition at post-mortem. Oh, that was a tongue twister, sorry. Finally, since sepsis is both a national and a Queensland health priority, it is important to be able to accurately identify sepsis-related child deaths. So as we saw at the beginning, sepsis was under-recorded on the death certificate. So to improve that ongoing monitoring and reporting, we recommended that where sepsis or the responsible pathogen is known, these should be documented on the cause of death certificate. So finally, what's really important about these recommendations is we've adopted a partnership approach to the implementation of them. We consider that it's not sufficient to simply make recommendations and hope or expect that an agency will implement them effectively. To achieve genuine and meaningful change, we really must stay for the long haul and work in partnership with the agencies to whom a recommendation has been directed to develop approach and to support it in its implementation. We should only really back out once it's become business as usual or standard practice, and that's the approach that we've taken in implementing these recommendations. Well, thank you.
And yes, so Beck and I probably just want to acknowledge the support of our wonderful teams and programs in doing this work. And she's correct. All of the agencies that are affected by our recommendations have been extremely welcoming and keen to work with us to improve where we're heading with sepsis, which has been wonderful. No, we've had absolutely no pushback from anybody, which is great. Everybody wants to improve. But at the end of the day, I just wanted to thank and acknowledge the involvement of our consumers in the sepsis program, who some of them are photographed here, who really are our inspiration and what keep us coming to work every day. Thank you.
Thank you.
Well, thank you, Paula. Thank you, Beck, for the really fantastic and fascinating piece of work. So thank you very much for that. We do have a couple of questions in the chat. The first one has been partially answered, but Paula, I might come to you for a clinical perspective. So the question was, how do you know if the children who were not that unwell died with infection, not because of infection? Could they have died during a seizure? So the team's provided a response from the child death prevention perspective, but you may be able to address the clinical side, please.
So the question really is what you consider sepsis, and the broad church of the definition is infection plus organ dysfunction. If an infection causes a febrile convulsion from which you die, that is sepsis, because the organ dysfunction is cerebral, and the vast majority of children do not die from febrile convulsions. It stops with under 5 minutes in 95% of them. So if a child is dying from a seizure from an infection, that is sepsis. So they're dying of an infection and not with.
Okay, thank you. Next question, are the deaths in the medically chronic children partly due to limitation of care? For example, families may choose to limit treatment to oxygen via nasal prongs and oral antibiotics only, so death from sepsis may be more likely.
Beck, you're probably better. This is a methods. You're probably better off.
Yeah. Look, I think that they probably could be, but that was one thing that our study didn't have good oversight of. So we weren't able to go back and individually look at what kind of palliative pathway each of the medically complex children were on. That was beyond the scope of our study. I think that is a really important question. And I think it is likely that in some of those kids, they would have had a ceiling of care. In others, their medical complexity was such that death from one cause or another probably was anticipated. And we saw a really high crossover, particularly in children with profound sort of neurological issues between that and respiratory infections. And those things are known to be linked in the research literature.
Thank you. Was there a difference by organism in deaths if recorded, e.g. by rapidity of onset of disease or deterioration?
We didn't look in that sort of detail. We certainly did look at what bacterial and viral infections and what we had. There was no changes over time, but we didn't look at time of onset we just didn't have access to all of that information or the ability to do that.
Great, thank you. And I have, is it possible to have access to your slides?
Yeah, I'm sure.
Right, I will circulate those after the session.
Everything that's in our slides, everything that's in our slides is in the report. So you might as well just take the report.
Great, we'll make that available to attendees after the session. I'm conscious of time, so I'm going to wrap up questions there, but if there's anything that remains unanswered, I'm sure we can revisit this offline. So just to say once again, thank you so much for taking the time to join us today and share your knowledge.
Thank you.
Okay.